A very warm and pleasant evening to everyone present over here. Today, I, Aman, Gangwar, moderator of this session, welcomes you all in today's webinar on postpartum hemorrhage conducted by ThinkMED. Now, I would like to introduce our guest speaker, Professor Dr. S.P. Jaiswar ma'am, who is currently serving as the head of Department of Obstetrics and Gynecology at King George Medical College. Talking about her achievements, I think a day won't suffice for that. Ma'am has an impressive list of achievements, including being an expert in managing high-risk pregnancies, a specialist in oncology, a guide for PhD students, a president of LOGS, and a member of various prestigious medical organizations such as ISOPAR, POXI, UPCOG, AICOG, NARCHI, URPSSI, IUGA. Additionally, they serve as a member of the Ethical Committee for the State Medical Council in Uttar Pradesh, chairperson of Horticulture and Aesthetic Committee, and a master trainer for SISPSA, FOGSI, EMOC, PPIUCD, lab ligation, mini lab, CAC, PPSEMC. Moreover, they are also an IGNOB counselor for PGDMCH course, displaying their commitment to education and training in the medical field. Now, I would like to hand over platform to ma'am for enlightening us on the topic. Ma'am, please.
Thank you. Thank you so much for kind introduction. Here I am Dr. S.P. Jaiswar, the Department of Sriani, heading this department of King George Medical University. So today you have chosen the topic about the postpartum hemorrhage. Why this topic is so important? Because we know this is the big cause of maternal death, and not in our India but all over world, even in advanced world also it is responsible for the death of the mother. So the postpartum hemorrhage is an obstetrics emergency complicating 1 to 10% of all deliveries. It continues to be leading cause of obstetrics cause of maternal death. According to WHO, each year around 14 million women experience PPH, resulting in about 70,000 maternal deaths globally. This is a big amount of maternal death, and thing is that is all preventable death. If we manage the patient in time, we can able to save these mother who die after delivery of the baby. The incidence varies according to region, and highest prevalence is in Africa, ranges from 5 to 25%. In North America is 3 to 13%, and even Asia is between 1.9 to 8%. This is the recent data. Now the question arises, why are we worried about the PPH? As we know, we see the causes of maternal mortality. In India, we can see the 70% women die because of hemorrhage. And in this 27%, the 40% is due to PPH. And this hemorrhage is the largest contributor of maternal mortality in India. Now come to, as we can see the other causes of maternal deaths like rupture uterus, eclampsia, infection after delivery or during delivery. These are the things has enough time to save the mother, but PPH has only 2 hours to save the mother, and this is also preventable. So we should know when we can call the PPH. As no, after delivery there is a blood loss occur, there is no doubt. So but the limit has been taken as a 500 or more after vaginal delivery and 1000 ml after cesarean delivery. This is about the amount of blood loss. But if the patient who is having 6 gram hemoglobin, even the 100 ml blood loss may be dangerous to the mother. So in this another definition has been added, like once the blood loss can cause hemodynamic instability, means even this amount of the blood loss which is responsible for the instability, we can consider as the patient is having PPH. Or if you see the hematocrit value, if there is a loss more than percent, to be considered in this definition. There's a lot, many guidelines shows the is given about the to define the blood loss for the PPH, like American College of Obstetrics Gynae, Dutch Society, Federation of Obs Gynae, and there's so many, even International Federation of Gynae and Obstetrics, like FIGO Society. All of them, they consider in vaginal delivery more than 500, and for the cesarean more than 1000 ml is called as a, should be called as a PPH. But according to Foxy, Federation of Gynae Society, even the more than 500 ml blood loss should be regarded as a, should be considered as a PPH, and if the loss is more than 1000, it should be considered as a severe PPH. Now come to what are the immediate causes of PPH. The PPH, these are the 4 T's, is the responsible for the primary PPH. What are these 4 T's? Uterine tone, retained tissue, genital tract trauma, and sometimes there may be coagulopathy. So these are the factors which can cause PPH. But in the most of the common, most of the cases, the primary PPH is due to uterine atony, 70 to 80%. And usually, what happens once the patient start bleeding, and then other factors also add in. Now come to the what is the essential for production. Stay. So what is the essential for prediction? So we can predict either by identifying the risk factor which occur during antenatal, intranatal, or postnatal. And if you define as a primary or secondary PPH, if the PPH occur within 24 hours is called the primary PPH, and within 24 to 12 hours to 12 weeks is called the secondary PPH. But the early diagnosis is very crucial to save the mother. If you see the risk factor, it can be included as a general factors, previous obstetric history, current obstetric history, previous uterine surgery, and associated factors. So the history is very important to find out, to make the patient is a high risk and can bleed. So the in antenatal, the important is about maternal age, nutritional status, whether the patient is booked or unbooked, and socio-economic factors, anemia, obesity. These all are the interrelated problem. And even anemia can, if the hemoglobin is already less, slight bleeding can cause the collapse of the patient. And if you go for the history, obstetric history, multipara, if there is a history of PPH, short inter-pregnancy intervals, current obstetric history, twins, multiple fetus, because the size of the uterus is big, placental size is big, so they all can cause the bleeding. So increase liquor, microsomy, anomalous fetus, these all are responsible big size of the baby and big uterus and can cause the PPS. If the patient is having previous history of uterine surgery, that is also important, like cesarean section, MRP, myomectomy, repeat DNC, corrective surgery. These may cause adhesion to the placenta and can cause the bleeding, maybe during antenatal, even in the postnatal. Now come to see the associate factors like diabetes, heart disease, renal disease causing anemia. Because in the chronic renal disease, there always is associated with the anemia, we all know. Pre-existing coagulopathy or coagulation disorder, or the patient is having on some drug, like if she is having anticoagulant drugs, can cause excessive bleeding. If you see the intranatal risk factors like APH, IUD, prolonged rupture membrane, pyrexia, use of tocolytics or anticoagulants, IVF treated patient, induction or augmentation of labor, prolonged first and second stage, precipitate labor. In these conditions, the activity of the uterine musculature is not so good, and so these patients can land up into the PPS. So if there is a history, be careful about the uh, to the PPS and be ready to manage that. Factor increasing chances of laceration like cervical, vaginal, perineal tear, like big size baby, shoulder dystocia, instrumental delivery, they can also cause the bleeding. So we have to see the causes and be careful when we are delivering the patient. So history, examination, and management all are important to manage the pregnant woman. Now come to the how we can predict the severity, because we know the change in the vitals comes quite late, but we can't allow the patient to bleed up to that extent. So the vital signs definitely is a predictor, but it's not very reliable. We can watch the pulse, blood pressure, and circulatory changes, but as I told, it comes quite late. We can use shock index. Shock index means the shock index, how we can calculate the shock index, pulse rate upon the systolic blood pressure is a more reliable. And if the pulse shock index is more than 9, means pulse is more and the BP is less, definitely the it shows the adverse outcome. These are the chart which showing the classification of severity and along with their clinical assessment. If the patient is bleeding, it can be classified as the class 1, class 2, class 3, and class 4, depending upon how much blood loss is there. If the blood loss is 15%, means 500 to 1000 ml, still the patient remain in a compensated form, and pulse may be normal, blood pressure may be normal, and even the mean arterial pressure is also ranges between the 80 to 90, but sometimes patient may have postural hypotension. If the blood loss is between 20 to 25%, this is considered as a mild grade or class 2. The blood loss between the 1000 to 1500 ml. In this, there is a tachycardia starts and the pulse can increase up to the 100 per minute, but the blood pressure will remain normal and mean arterial pressure will also remain normal. But these patients can go into the peripheral vasoconstriction. In class 3 or moderate type of PPH, in this the blood loss is up to 30 to 35% or 1500 to 2000 ml. Pulse further increased to 120. Now the blood pressure is also coming down and systolic becomes 70 to 80, and mean arterial pressure also comes down to between 50 to 70, and the patients become pale, restless, and is going into the oliguria. This is the condition which is, if you manage it this till the patient's condition become reversible. But once she goes into the severe PPH or class 4, when the blood loss is more than 40% or 2000 ml, in this the tachycardia increases up to 140 per beat per minute, systolic falls to 60, mean arterial pressure to 50, and in this the patient is collapsed. She becomes goes into the anuria and hair hunger. This is a very crucial condition because in this the patient can go into irreversible shock as well as the multi-organ failure. So be careful when the patient is losing blood after delivery. So how can we can estimate the blood loss? Either by the visual estimation, by the extent of soakage of pad or towels, or we can estimate by use of calibrated delivery drape sheet. Here this is a pictorial guide for the visual estimation of blood loss. We can see that if there is soakage of sanitary towel, superficially is 30 ml, but it's completely this is 100 ml. If there is a swab of 10 into 10 centimeter soaked, is 60 ml, or if there is an incontinence pad is 250 ml, and there is a large soap swab of 45 into 45 centimeter is 350 ml, and if the spill goes 100 centimeter is the loss is 1500 ml, and if whole bed is going on then the 1000 ml, and the blood is going trickling to the down also then 2000 ml, and if the kidney you can by the kidney you can see the kidney full kidney is 500 ml. We can use brass V drape also. This is the name as an excellent brass V drape, and this is modified version is used for the blood collection, and this is very good because it has low cost calibrated uh, plastic. This is a plastic form drape and can be used in laboring women. This is kept under the buttock of the mother and who is delivering, and after delivery of the baby, when the liquor is already drained, then the after that the blood should be collected in and can be seen how much the blood the patient is losing. You can see there is a one yellow line shows the warning level, and this red line shows the action. So if the blood has come to red line, means the blood is loss is more than 500 ml. Now come to how we can prevent. For prevention, we should do the active management of third stage of labor, and we always taught in to the MBBS students, even our PG student, that is very important step to prevent the PPH. In this, the active management of stage, active management of third stage includes use of oxytocins, control contraction, and uterine massage. So these are the three important component of this active management of third stage of labor. We can see the administration of uterotonic. Whenever you are giving oxytocin 10 international unit intramuscular, first you check the patient should not have another baby inside the uterus. So after confirming the patient has delivered, there is no another fetus inside, you give muscularly after delivery of the baby. Wait for some time, uterus contract and the placenta separate. Once the placenta separate, then you can see the bulge, suprapubic bulge, and the uterus will be well contracted. In that, do the control contraction. That is very important. We taught our MBBS students also some modified band and use technique, because in this the uterus should be pushed up and the cord should be pulled down to prevent the inversion. But if the uterus is relaxed and is not separated or is having morbid addition of the placenta, in that situation there may be inversion of the uterus. So unless you are very sure, don't do this procedure. And the wait for the watch the patient, that is the fourth stage of labor. That is very important and included in your textbook, because in this, if the uterus relaxed, patient can go into PPS. So you have to monitor the patient for the uterine tonicity. Uterus should be contracted. Check the bleeding every 15 minutes up to the 2 hours. If it is remain contracted, the chances of PPH is less. And if there is a uterus atonicity, do the fundal massage and monitor the more frequently. Now come to the management. So in management, if the patient is already having PPH and you have done the active management of stage of labor, still the patient is having bleeding, so it should be managed. Call for the always managed by the team, because alone you can't manage. So you ask the team to help you. So first you start the IV fluid, and once you are putting the IV cannula, it should be of wide bore, and the same time take the blood sample for cross match and hemoglobin. And the preferred fluid is only ringer lactate. It should be given, it can be given 3.5 liter very fast to replace the fluid, or till the blood is coming, you can supplement this fluid. If it is still delay, then you can add the crystalloid 3 to 5 ml per. But this ringer lactate or normal saline is the choice. But if the patient needs lots of blood, then lots of blood is already having lots of blood loss. In that situation, the patient needs blood transfusion in the form of PRBC, FFP, and RDP. And the ratio should be 1:1:1. That is very important. So in this chart, you can see what are the things to be given. And this is given by the RCOG 2016. As already I told you, the crystalloid is the preferred choice, then colloid, and if the blood is available or till that the blood has come after cross match, then it's okay. Otherwise, you can give ORH negative blood. If there is no blood is same blood group of is present. So FFP is used if there is a continuous bleeding, the patient is having continuous bleeding and the PT and APTD is prolonging. It can be given by the dose of 15 to 12 to 15 ml per kg. Platelet concentration is required when the platelets falls below 75,000. And sometimes we need cryoprecipitate, and if we are giving these things means the patient needs massive blood transfusion, and massive blood transfusion has in their own side effect, and sometimes the patient can go into the blood reaction or acute respiratory failure also because of massive. So be careful when you are giving the blood and fluid. Medical management includes the use of oxytocics, in which we have oxytocin, methyl ergometine, 15 methyl PGF2 alpha, and misoprostol. The misoprostol is very good, especially when the delivery is conducted by DAI or ANM or at periphery, when there is no one to give the intramuscular or intravenous drug. So once the patient delivered, 800 microgram misoprostol or PGE2 can be used per rectally when the patient is a high risk or can go into PPH. Otherwise, these drugs can be used in the form to as a oxytocin. Oxytocin is quite useful. It can be given 20 units in 1 liter in the rate of 150 ml per hour. But maximum is 10 units. We cannot give more than that. And in diluted form can cause pulmonary edema or hypotension. So whenever you are giving, be careful. Methogen or ergometrin is quite useful to prevent the make the uterus contracted, but only thing is that it should be avoided in hypertensive, pre-eclamptic patient, RH negative, and cardiac disease. Even in the severe anemia, it should not be given because it can cause sudden blood goes suddenly towards the heart and can patient land up into the cardiac failure. 15 methyl PGF2 alpha can be given in the form of intramuscular 250 microgram every 15 minutes, but not more than 2 milligram. But if the patient is sensitive to prostaglandins or having history of asthma, renal disease, or cardiac disease, it should not be permitted in that. So the aim of is to maintain the hemoglobin more than 8 gram per deciliter, platelets count more than 50,000, PT-INR should be less than 1.5 times normal, APTT less than 1.5 times, and fibrogen level more than 2 gram per deciliter. Sorry, per liter. These are the few steps with the patient. We have given the medical management. Still the patient is having atonic uterus, then we can go for the manual compression of the uterus in one, and it should be done with the sterile manner. The patient should be painted in with the sterile gloves. The one fist should be into the anterior vaginal wall and another one above the abdomen suprapubically to make the anterior and posterior uterine wall together to compress the uterus and minimize the bleeding. If this therapy fails, then we have to do some other measure also, like aortic compression or use of non-pneumatic anti-shock garment. These are important things, and every PSC CSC should have non-pneumatic anti-shock garment because it helps in the transferring of the patient from to the higher center. This is the picture. You can see the non-pneumatic anti-shock garment. It has 1, 2, 3 segment. which is put on the limbs of the woman. Fourth is on the pelvis. Fifth and sixth on the abdomen. But be sure the upper level of this garment should not cover the rib, otherwise the patient will not able to breathe properly. It's, it's a mechanism is that it causes shunt of blood from the lower extremity to the central part, or prevent the damage of the mm, vital organs like kidney, liver, heart, and brain. So it is very important when the patient is in the shock. It causes, it is a very helpful, especially you are transferring the patient from the periphery to the higher center. So in this picture, you can see how to use this anti-shock garment, non-pneumatic anti-shock garment. If the patient is conscious, you can ask the patient to uh, uh, raise the thigh and put the fourth fourth segment below the buttock, and fifth and sixth in the thoracic region. Here we can see how the this girl is putting, nurse is putting on that, because it can be done by the paramedical staff also. It's a very helpful in preventing the maternal death and going into the irreversible shock. So here this you can see the number 1 is near the ankle, number 2 is near the calf, and number 3 is near the thigh, and fourth is on the pelvis, and fifth and sixth on the abdomen. Fifth is having ball, which should be kept on the uterus to compress the uterus, and sixth wraps it. For this, for the limb, we need 2% to tie, but above one can be done by the single person. And after putting this, you can see how it is. Put 1, 2, 3 is on the limb, fourth on the pelvis, and fifth on the abdomen and abdomen. Fifth and sixth is on the abdomen. This is important snap test. When you are putting, just put your finger beneath that and just raise this garment. You will get the snap test, means snap sound, means the tightness of the garment is adequate. If it is not, then you can tie it again, give a proper pressure on the lower limb. Aim of the treatment is again to decrease the pulse rate, increase the blood pressure, and increase the urine output, because these are the vital organs and they have come into the normal state. But it is contraindicated in heart disease. As I told, once the whole blood goes towards the heart, the patient can go into heart failure. So be careful and see whether the patient is having this problem or not. And the removal is also very important, because we cannot open at a time. Start from the lowest, number 1, which is near the ankle. Wait for the 15 minutes. If there is a fall in the blood pressure or rise in the pulse, wrap it again, tight it again. But if the patient is stable, then remove the second number. So after the 15-minute gap, that is very important. And that is also important till the blood has come, you can transfuse the blood or supplement the fluid loss. This is compression of abdominal aorta. It is also helpful till the blood is coming or you are preparing the OT for the surgical management or shifting to the OT. Stand on the left side of the mother, put the thumb on the abdominal aorta in such a way that the femoral vessel become non-palpable. If the femoral vessel become non-palpable, means the pressure is adequate, and keep it till you are preparing the OT or other person is preparing the making ready the OT. So these are the other method we can use to prevent the bleeding, like balloon tamponade, hemostatic brass sutures, bilateral ligation of uterine arteries, bilateral ligation of internal iliac arteries, and sometimes selective arterial embolization is also helpful, especially when you want to save the uterus. Like if the patient is priming, we can't do the hysterectomy. So in that, this can help. But you should have facility of selective arterial embolization, which we have in our institution. Hysterectomy is the last resort. When to save the mother's life, we have to go for that. In balloon tamponade, we put the balloon filled with the 300 to 500 saline solution, and it can be kept up to 24 hours or even more. If the patient becomes stable, then we deflate in a not in a slow manner, like 10 to 15 minutes. At the interval, we remove the 50 ml of fluid, then wait for 2 hours, see the everything is okay. Then after 2 hours, remove the again 10 to 15 ml of fluid, and by this, once the patient is stabilized, then we can remove the balloon completely. But if the patient start bleeding again, then fill and put it for the further 24 hours. In 77 to 80% cases, 88% cases, bleeding stops by balloon tamponade. In our labor room, even our residents are very expert to putting this balloon tamponade, and is quite good for the mother to save the mother. These are different type of tamponade. You can see Foley's balloon catheter, Bakri balloon catheter, Sangstein, Blackmore, Rush, and condom catheter. We usually make in our hospital, we use condom catheter because the condom is easily available in the labor room, so can be used. In this picture, you can see the Bakri balloon is inside the uterine cavity. It is compressing the bleeding surfaces of the uterus and preventing the blood loss. Again, you can see the picture of Bakri balloon and condom catheter and how it fit into the uterine cavity. This is a very useful balloon, making the balloon. This is called the Chhattisgarh balloon, and it is invented in our own country, in Chhattisgarh, Raipur hospital. So it is still known as the Chhattisgarh balloon. In this, we use Foley's catheter, which is available in our labor room, along with the condom. And to tie the condom on the this catheter, we use the ring of Foley's catheter. In this picture A, you can cut the ring to two ring and put on the both side of the um, condom, and you can learn easily to prepare, and it's very good because it blocks the cover, occupy the uterine cavity and stop the bleeding. Now come to the surgical management. The surgical management is the last thing which can be done in the operation theater, and have where the facility of anesthesia along with the, sometimes the patient is such a low condition, can be kept on the ICU also. So in this, we use compression suture in the form of B-Lynch, Heman, Joe multiple square, or we can do the stepwise uterine devascularization, means bilateral uterine artery ligation, bilateral ovarian artery ligation, but ovarian artery ligation should be done after and at the cornu, once the ovarian artery has given branch to the ovary, and can do the internal iliac artery ligation. In this, we have to choose the anterior branch of the internal iliac artery because posterior cannot do, otherwise the patient will have gluteal muscle damage. And uteri artery ambulance already told you. So about the B lynch, you can see in this picture how the B lynch has been given. Started when we are doing the cesarean section, and the patient uterus is absolutely atonic and relaxed. In that, the stitch should be started 3 centimeter medial and below the lower scar, then can be should be taken out from the upper margin, go behind, enter into the uterine cavity, and then again comes out and come anteriorly. In this, you can see how this anterior and posterior surface of the uterus approximate to by this tightening these stitches, and the bleeding stop. Here, this is the Heman sutures. When the after normal delivery, when there is a uterus is not scarred, we can put these stitches to approximate the anterior and posterior surface of the uterus. Joe stitches are the multiple square stitches which is used to approximate the anterior and posterior surface of the uterus, and more useful in the case of placenta previa or adherent placenta to stop the bleeding. This is the picture showing the how we do the stepwise devascularization. You can see in this picture below here, this is the uterine artery has been ligated in this, in which we include some amount of musculature also. Sometimes once we want to include the descending cervical, in that we have to push the bladder down and go up to this stage. And for ovarian should be given just below the cornua, because this vessel, if you include this vessel, ovary will also destroy. So this is the stepwise devascularization. It can be done unilateral or bilateral, and depending, once the bleeding stop, we can stop there only. This is the ligation of internal ileg. Again, it can be done bilaterally, because from uterus get the supply from the both side. This is the anterior branch, and this anterior branch should be ligated. This is the posterior, which is going to supply the gluteal muscle. And by this, we can reduce the blood loss up to 50%. Uterine artery embolization can be done if you have facility, but in this we need the interventional radiologist to help us, and can put the catheter before taking out the baby, especially in the case of placenta increta percreta, or placenta previa, when we know that there is a chances of bleeding. It is quite useful, and the catheter is already put in the selective vessel, and after taking out the baby, we can embolize the vessel, and after that we proceed for the further action. So this, by this method, we can avoid the hysterectomy, but the hysterectomy is the last one to save the mother's life, especially where there is no facility of other procedures. So in that situation, a subtotal hysterectomy is the best, because it takes less time, and it cannot and can be done easily. But in case of morbid adhesion or low lying placenta, we have to go down to. And sometimes, if there is case of increta percreta, we need people. This should be done in the tertiary center, along with the multidisciplinary actions. Means we need a urologist, we need ICU facility, we need neonatologists. So these patients should not be taken at the level of small setup. Once you know the patient is having low lying placenta or placenta previa or increta or percreta, should always send to the higher center where there is a facility is available. This is about the traumatic PPH. The uterus is well contracted, still she is having bleeding. Then you have to find out why she is having bleeding. Although the amount of blood loss is not so acute, but still, if you are not able to close it or not to find out, then in the patient can collapse after some time. So whenever the patient is still having small amount of bleeding or even trickling after, when the uterus is contracted, then you have to see for the traumatic PPH. If she is having traumatic PPH, maybe laceration of cervix, vagina, or perineum, or extension of episiotomy, you have to repair. Sometimes what happen, this extension goes into the lateral wall and involve the uterine artery. In that situation, we need the laparotomy also, because we cannot stop this bleeding from down per vaginally. So in this, the patient needs laparotomy. So whatever I talk, this is about the primary PPH. But sometimes what happens, if the patient is coming with the bleeding after 24 hours, then it comes into the secondary PPH, and usually it is because of retained tissue or infected tissue. So whenever the patient comes as a secondary PPH, then she needs proper exploration. This is the PPH emergency response bundle given by the Division of Global Health Innovation, Massachusetts General Hospital. In this, you can see the topmost is the active management of third stage of labor. So if you have done, still the patient is bleeding, then call for help, because you cannot manage the patient alone. So you ask the patient, multiple people, maybe you're the one doctor, one paramedical, one staff nurse, or even Aya can help you in this. So you have to call the people. In this PPH emergency response bundle shows these has a multiple steps, but sometimes these steps can be done required together, like uterine massage, IV fluid, uterotonics. In this, a tranexamic acid has been included in this, and even the tranexamic acid gives very important, very useful response, and it should be given as a 1,000 milligram IV in 3 to 4 minutes, but within 2 hours of delivery, or it can, and if it is required within 30 minutes, you have to repeat it. After that, it does not work. So it should be given as early as possible. But if there is no answer, no other things, you can use it again. Supportive measure includes repair of the tear. Sometimes full bladder is also responsible for the uterine atonicity and bleeding or retained tissue. So you have to explore them at the same time. If still the patient is not responding, then you have to use a reflective BPH intervention like compression of the uterine compression, abdominal aorta compression, uterine ballooning, and anti-shock garment. And if you are working at the periphery, then need transfer of the patient to the higher center along with the blood transfusion. The patient is requiring surgical management. So why this PPH emergency response bundle is useful? Because it increases the efficiency, avoid the missing intervention, and improve the team performance, because there is a teamwork, and teamwork is always good to give good response. So, how we can prevent at community level? We can prevent community level by the awareness, the risk of PPH. If there is a history, or the patient who is having risk factor like twins, anemia, or low-lying placenta should be transferred to the higher center. Patient should be with good birth preparedness, means you keep the hemoglobin high, give proper antenatal checkup, good nutrition, and birth should be conducted by a trained person. So in that, at community level, we can reduce the chances or incidence of PPH, chances of PPH, or if there is a PPH, at least the patient can be managed in time and can prevent the maternal death due to PPH. So these are the PPS drill is also important. Even in our setup, we do the PPS drills, and it shows. And by this doing drills, our nursing staff, our employee, our residents, they know what to do and what time they should do. So it should be given continuously. It's a life. What handicaps? Where is the handicaps comes? Handicaps comes in the form of delay. First delay as recognizing the complications. Second delay, deciding to seek care, because in the family sometimes the mother-in-law is not ready, father-in-law is not ready to go to higher center. Third delay is because of transport proper. There is no road, there is no bus, no, if there is no ambulance, if that ambulance is there, there is no driver, a driver is also there is no petrol in the ambulance. These are the factors. The fourth delay is receiving the care at facility, like at our place. Once the patient is coming, somebody rings us, send the message that we are sending such and such patient, and we keep everything ready to avoid this delay. So by this, we should identify and manage in time. By this triaging, we can reduce many mortality and morbidity due to PPH. So prevention can reduce the PPH. Prevention may be at community level, and this is the emergency PPH emergency care. When there is a one person who acts as a leader, then data monitoring, quality improvement, respectful maternity care, facility readiness, network integration, teamwork, and communication. The all can prevent the can is a part of PPH emergency response and help in managing the PPH in time and preventing the maternal deaths. So take home message, accurate prediction, adequate prevention, and timely intervention can save many lives. Thank you.
Thank you so much, ma'am, for such a fruitful session. It will make a difference indeed. In country like India, where cultural and regional factors plays an important role in decision making, how should healthcare providers address these challenges to manage postpartum hemorrhage?
I told you now in the last slide what are the hurdle, what are the problem. First is delay in, there's a four delay which are responsible for maternal death. If we prevent this four delay, we can save many life. One is the person is not able to identify whether the patient requires referral or not. Second thing, if it is their people, their relative, they are not agree to take the patient at higher center. Third is that if they agree, there is a no vehicle, no road properly. And fourth thing, once they reach to the higher center, the doctors are not prepared to handle in time. So these four delay, if we work on these four delay, we can prevent many deaths, not only by PPH, when other conditions also like obstructed labor, APH, severe anemia, hand prolapse. There's so many patients who comes to the our institution. So in that, how we can prevent? For prevention, very important is the awareness. As we know, the maximum delivery occur at periphery, and this is either by the ANM, ASHA worker, or trained done. Now, our government encouraging hospital delivery by giving some incentive in the form of JSSK, JSY. These are the things which is given by government. But still, the people they do not want to come to the government setup. This is lots of query also, there's lots of problem also, but we have to counsel, we have to prepare. Once the patient has become pregnant, if she is taking proper antenatal checkup in the hospital, she is having proper diet, her hemoglobin is about 10 gram percent, she is not hypertensive. In that situation, even she can tolerate some amount of blood loss. But if this deficit is in the form of hemoglobin, or she is a hypertensive, or she is a case of high risk, definitely they are having problem, high risk case, and should be counseled during antenatal period to reach the place where she can get safe delivery.
Ma'am, here is another question from Ms. Himani. Ma'am, can you please highlight some of the supports and resources which are available for patients from government side for women and families which have experienced postpartum hemorrhage?
It is a difficult to say ki which woman will go into PPH. You don't know. Even primary patient with a low risk
Yes,
patient
ma'am.
without any high risk can go into PPH. Clear? So
Yes, ma'am.
PPH is not a preventable. Death due to PPH is preventable. Like pre-eclampsia, eclampsia is not a preventable, but you can't stop by occurring. But definitely you can stop or can minimize the complication which is associated with this. So similarly here also in the PPH, that's why the WHO recommended active management of third stage of labor to every woman, whether she is a primary, whether she is a multi. So if you have done that, the most of the cases primary PPH can be prevented once the uterus is well contracted. Problem occur in the case when the uterus is not well contracted or having high risk factor. So in that we should be more careful and should send the patient to the setup where she can be managed.
Ma'am, this next question comes from Saida Pula, who is asking, what if heavy bleeding occurs and physician is posted in a low infrastructure facility?
I told you the definition, the blood loss, how much blood loss can cause can be considered as a PPH. Like in vaginal delivery, 500 ml, cesarean section, 1000 ml. But in this situation, her hemoglobin should be normal. But if the patient is already in anemia, severe anemia, even the 100 ml blood loss may be dangerous to her life. So in that, you have to be careful how much hemoglobin is there and prepare yourself to manage the case. because at periphery, if the patient is 6 gram, 7 gram, 8 gram, she's having normal delivery. Still, she can collapse because of slight loss of blood. According to definition, she's not having so much blood loss, but still she can collapse. So in this situation, you can't ask them these patients to deliver the places where there is no facility.
Ma'am, I would like to also ask if there is any specific guidelines for referral of any such patient.
Guideline of referral, pardon?
Ye- Yes, ma'am. For
Yes,
if there is
yes, we have made we are giving lots of training. Many uh, training training means we asked we trained medical officers in our institution how to handle the high risk cases, and after that we go and see that places, PSC, CSC, Jila Aspatal, to see how they are doing it properly or not. We have developed protocol also for PPH. We keep chart in the labor room, or to how chart of everything, how we can monitor the labor, how you can maintain the partogram, where how can you detect the patient is going into prolonged labor. So these are the, if you maintain the partogram, you keep the chart in your labor room, even when there is a change in the shift, the another person who is coming on duty can make out where is the problem and can manage there. So we have to maintain these things in our labor room. That is important to detect, because partogram, there is a alert line, there is a action line, and one person cannot stay for 24 hours. After some time the duty change, the another person comes, but the partogram, looking the partogram can make out whether this progress is normal or is going there is a delay. So by this you can identify the things early and can manage timely.
Okay, thank you, ma'am. Ma'am, there is one last question from Dr. Harshit. Ma'am, he is asking that how can healthcare providers effectively educate and empower pregnant women and their families about postpartum hemorrhage and its potential risks?
So everything you are asking is related to postpartum hemorrhage. I'm saying
Yes.
we can't say which woman can go into PPH, because
Yes.
only you can identify the high risk factor. This high risk factor may be in the antenatal period, even it can be in the intranatal period also. The patient goes into prolonged labor, it's the intranatal period, or patient is going into obstructed labor, it's the intranatal period. You have not assessed the malrotation or the occipitoposterior position or shoulder dystocia before. Again, this is the intranatal complication. So you have to identify, you watch the patient properly during her antenatal, if possible, during antenatal visit, every antenatal visit, to make find out the high risk factors like anemia, preeclampsia, hypertension, heart disease, multiple pregnancy, low-lying placenta, scarred uterus. You can see, and the very important is now the trend of cesarean section. And with after cesarean section, we don't advise, or if the patient does not follow proper family planning procedure method. So she will conceive after 3 months, 6 months, and within 2 years she will have another baby, can cause rupture uterus, cardiac. So these are the important things which we can teach, train, advise during antenatal. Intranatal is in our hand, or the person who is monitoring the labor is in their hand. So if you have monitored the labor properly, use the active management of third stage of labor, definitely the many PPH can be prevented.
Okay, thank you so much, ma'am, for
Labor is also important. What happened after delivery? Everyone become busy with the mother, with the sorry, with the baby. Relative become busy with the baby, and the staff become busy with the another patient, and the mother become neglected. And this first, that's why this the fourth stage of labor has been added in our stages of labor, because the maximum problem occur during this period. Maybe there is a PPH, heavy embolism, or patient may collapse. So that proper monitoring for 2 hours after delivery is very important. And once the patient is stable, then she should be shifted to the ward. Clear? Every
Yes, ma'am.
every labor room and should have PPH corner. All facility of PPH like oxytocin, IV line, crystalloid, police catheter, this with on should be on the PPH corner. So PPH corner should be in the labor room as well as in the PNC ward also to manage the patient as early as possible.
Okay, thank you, ma'am, for answering all the queries of our participants. It will definitely benefit us. Now, I would like to invite Kumar Saurabh, Secretary of ThinkMED, for the vote of thanks.
Thank you so much. Thank you.
Good evening, Professor, and all the attendees. This is Kumar Saurabh, the current secretary at ThinkMED, and I want to take a moment to extend my heartfelt gratitude for the wonderful webinar delivered by you on postpartum hemorrhage. I'm truly grateful for the insights and knowledge Professor shared during the session, especially the information regarding the shock index, the importance of shock index over the vitals, and also the visual estimation of blood loss and the importance of NSGs in management of postpartum hemorrhage blood loss. The depth of understanding which was demonstrated here not only enhanced my comprehension in parts of the topic, but also ignited a greater interest in delving in obs gynae today itself. And I'd like to say special thanks to ThinkMed's president as well, Mr. Vaibhav Singh, our joint secretary, Ms. Rudrakshi, and also our moderator, Mr. Aman, who played pivotal role in organizing this event. At last, I would express my gratitude towards all our attendees and ThinkMed members for their presence in the webinar. And I'll say that please stay tuned with us for many upcoming webinars, quizzes, research opportunities, and many more informations related to the field of medicine. So you can join us on various social media platforms, and we love to hear from all our attendees if you have any queries, or you can also mail us on our official mail ID, which is thinkmedex at the@gmail.com. So that's all from my side, Professor. Thank you for the very nice session. It was very useful. Thank you.
Thank you so much. At least it has generated interest in
Yes.
Obsgani. Obsgani is definitely a wonderful subject. And if you feel satisfied or very happy once you're able to save mother and baby, that is really awarding. Thank you so much.